Well, thank you very much. It's a great pleasure to be here with you today. I want to thank Rick for that introduction and for inviting me here with you to this special session to share with you some of President Trump's vision and HHS's vision for the future of healthcare. I also want to recognize that this is not only Public Service Week, where we're recognizing all the great folks at HHS and throughout the government, but also National Hospital Week and National Nurses Week. I guess we're running out of weeks. We're getting like tri-stacked here now. And I also really want to thank Rick and the team here at AHA and the membership of AHA for all of your support and help. We're dealing with some of the most intractable issues in any modern economy when we talk about healthcare and the service delivery process. And the partnership of AHA is really invaluable to that, and we always seek out your input and value that. So thank you for that work. I do believe we're in an exciting moment for healthcare. It's a time when we all agree that change has to come to this industry faster than it's ever come before. Certainly, America's hospitals are in the midst of many changes, and on the cusp of many more. I'm sure some of you recall the headline of my friend Zeke Emanuel's op-ed in the New York Times earlier this year. Quote, "Our hospitals becoming obsolete." I suspect that made it to the top of a lot of your reading piles that morning. You know, the peak year for hospital admissions in the United States was 1981. Despite a 40% increase in population over the same time period, the number of hospitals in America has actually decreased from just under 7,000 to about 5,500. Zeke pointed out a number of factors driving this trend. Technological advances in recent decades have allowed more and more procedures like chemo, joint replacements, and many cardiac procedures to be done without an overnight stay or in a different setting. Great advances. We're also incredibly aware of the risks now that come with hospital admissions, from healthcare-associated infections to the downsides of spending all of that time lying immobilized in bed. But, and if I'm citing Zeke Emanuel, most of you would know there's going to be a but. This tale of hospitals becoming less important to our healthcare system is incomplete. After all, who was it who adopted new forms of chemotherapy? Who paid the pioneering cardiologists who found ways to heal patients without open-heart surgery? Who helped identify the very risk of healthcare-associated infections? That's right, America's hospitals. The tale of increasing hospital irrelevance is not borne out in all the data. Consider this. In 1960, the first year that the federal government ran the National Health Expenditure Survey, America spent $8.9 billion on hospital charges. Wow, that's like barely a line item at this point. Or 32.4% of the $27.2 billion that we spent on healthcare in total that year. Jeez, I can't even think of those numbers. 56 years later, in 2016, that share of health expenditures spent at hospitals remained almost exactly the same. It's actually a little higher at 33%. Large-scale hospitals, and especially overnight stays, are taking on more of a specialized role in our system. But hospitals, broadly defined, aren't growing irrelevant. As all of you know, they're transforming to provide the cutting-edge services today in a shifting array of settings. The movement of more and more services outside the four walls of hospital has been a positive one. It has, all else equal, lowered costs and improved outcomes. But as I said, even as this transformation is going on, we do believe it has to accelerate. That's why I've identified as one of the four priorities that Rick mentioned, the transformation of our healthcare system into one that pays for value. Today I want to talk about how we'll deliver on that priority and then briefly touch upon how we see a similar need for transformation outside of service delivery, and that is the way that we pay for prescription drugs. We at HHS know that the idea of value-based transformation is not something new. Both the George W. Bush administration, in which I served, and the Obama administration worked to move towards a system of paying for value. I personally spent a great deal of time working through this process under HHS Secretary Mike Leavitt. Since that time, many of you at America's hospitals have made very real progress on this front. But both our government programs and the private sector have a very long way to go. Everybody here understands that the system as currently constructed will not last. Something has got to change. So, during my first 100 days as Secretary of HHS, I laid out 4 areas of emphasis for building a system that delivers value in our healthcare system. First, maximizing the promise of health IT. Second, improving transparency in price and quality. Third, pioneering bold new models in Medicare and Medicaid. And fourth, removing government burdens that impede care coordination. The common thread for these priorities is the recognition that value is not accurately determined by arbitrary authorities or central planners. The best way to identify and reward value is a marketplace of many players, providers, patients, and where necessary, third-party payers. Progress is already being made on each of these 4 fronts that we've identified for value-based transformation. You heard from Administrator Verma on Monday about some of these efforts at CMS. That includes Blue Button 2.0, a system that will use open APIs to give patients the ability to connect their Medicare data to apps developed by private companies. We already have hundreds of companies who are seeking to put apps on top of this great data platform. Now, replacing Blue Button with Blue Button 2.0 may not sound on its face the most revolutionary thing on earth, but it is a new step forward, a new and major step forward in our work to maximize the promise of health IT by giving patients access where they want it, on their phone, to their own data. Blue Button 2.0 is a part of a larger administration-wide initiative called My Health eData, run by Jared Kushner and the White House Office of American Innovation. This initiative is designed to help patients access and share their medical data throughout their healthcare journey, while ensuring that their information is kept secure and private, and that they make the decisions about when to share it. We've spent more than a decade now talking about the importance of interoperability of health records. I can assure you I spent plenty of time around Mike Levitt's conference room table alongside our current HHS Deputy Secretary, Eric Hargan, trying to puzzle out how we could guide the broad universe of health IT actors to agree on interoperability standards. Today, progress has been made on interoperability. Progress has certainly been made on the electrification of healthcare records. But more importantly, new technology has made it possible for us in the government to be focused less on the how of interoperability and more on defining the what that is required. Patients ought to have access to their data, period, however you all and your vendors want to accomplish it. I had a recent reminder about why this is such a priority and why the benefits and challenges of health IT are not abstract, but real and significant for patients and providers. Many of you likely know that I spent some time in the hospital recently. This is, in fact, the first inpatient hospital stay of my adult life. My last time was when I was 7 and had my tonsils out. It is a particularly interesting experience to go through as health secretary, with the level of attention involved. My wife started joking that my press secretary had its own colon, that my colon had its own press secretary. In fact, she's here right now. The quality of care that I received in the hospital was remarkable, and I'm really very grateful to the staff who cared for me and really took care of every need that I had, from the nurses and the techs to the administrative staff and the physicians. Really just an exceptional experience. It was a reminder of how fortunate we are to have access to such high-quality care in America's hospitals. But the experience did bring home for me how challenging it is to be a patient. This is why it's dangerous to have the healthcare secretary as a patient of yours, because then you give speeches about it afterwards. And it reminded me just how much information and data are required to deliver the right treatment. So even though I stayed within the one hospital system for inpatient, outpatient, specialist, primary care, and diagnostic, lack of interoperability between multiple EHR platforms meant that I had to relay and repeat my medical history, my medications list, and the like to each new doctor or nurse who attended to me, or each check-in receptionist. Now, listen, consider that I found this a stressful experience when I've got years of experience in the healthcare field, decades. I consider myself relatively young and active, I mean, imagine if I had been a much older patient, one with no familiarity with how the healthcare system works or what information my doctors were needing or might need to know in delivering quality care to me. You know, today's compartmented system, it's a burden for both patients and providers. I mean, imagine if I could have shared my medication list just once. Imagine if instead of running through my story with each new contact, I could have told it just once. Think about the opportunities for mistakes that can happen and inaccuracies that would eliminate. And think about the time that would free up, the time for seeing more patients, offering them the care and attention that they need. Now think about that not just in the context of one guy with an angry colon, but across 330 million Americans. It is amazing what a freer exchange of information would mean for our whole system in terms of efficiency, cost effectiveness, and use of scarce provider time. That's the promise of interoperability. That's why I shared my personal experience, not because I want to call out any particular hospital system or their EHR vendors, but rather to reflect on how important it is to make progress. You know, we at HHS, we don't want to manage and micromanage how the system gets to interoperability, but we're going to provide the right incentives to make it happen. You know, more broadly, patients must have access to more than just their own health data. For individuals to drive value, they must have access to data on price and quality. Knowing prices and outcomes can enable every American to find better, cheaper health care. It may seem rather obvious, but there are plenty of naysayers out there who protest that health care is simply different, that market forces do not apply. But there's a significant body of academic work, in fact, on how price transparency can reduce costs while maintaining quality. We know empirically that when we empower healthcare consumers, market forces actually do work. One of the largest studies on this issue looked at more than 500,000 patients whose employers built a price transparency platform to inform them about the cost of various healthcare services. When patients used this platform to research prices, costs drop significantly, up to 15% lower for lab tests and up to 16% lower for imaging. Happily, we have this evidence because the private sector has already taken the lead on transparency in many places. But we at HHS can play a role in driving broader change. And in many cases, such as the scale of our programs, if we're not serving as an innovator, we very well may be standing in the way. Last month, for instance, in Medicare's 2019 proposed hospital inpatient rule, CMS unveiled new steps to drive greater price transparency. As of January the 1st, 2019, for instance, hospitals will now be required to post a list of their standard charges on the internet and in a machine-readable format, rather than just being required to make them publicly available in some form. Now, we know real transparency is going to require going a lot further than that. So we also included in that notice a request for information on a number of other transparency issues. For instance, how can we address the problem of surprise billing? I mean, we've all experienced it. I'm sure it's probably a daily complaint that you all as hospital executives get when someone goes into an ER and they end up with a bill later from an out-of-network physician or practice. It's just surprise billing. It's one piece. It's one part of the broader problem of the opacity in healthcare pricing. It's not an exaggeration to say that just about every hospital bill in America today is a surprise bill for folks. I mean, every time I check my email, I'm getting a new bill coming in from my recent experiences. I believe simply that you ought to have the right to know what a procedure is going to cost and what it's going to cost you out of pocket before you get it. We want your input on the best way to make this a reality, and we are going to applaud those systems and those hospitals and those providers who make this vision a reality on their own. The final two areas of emphasis for value-based transformation are pioneering new models in Medicare and Medicaid and removing government burdens that impede care coordination. Late last month, CMS took action on both of those areas too. To start, they released the more than 1,000 comments that we've received from stakeholders on a new direction for the Center for Medicare and Medicaid Innovation. While this new direction will involve collaboration and close consultation with stakeholders, we're also going to think big and bold. Adam Bowler, who's taken over that group, is going to provide a really needed direction and focus on how we can use CMMI not just to transform Medicare and Medicaid, but through it the entire system here in the United States by showing a better way on value payment. Alongside the comments that we received, we also released a new request for information about testing the concept of direct provider contracting within Medicare. Contracting arrangements like direct primary care have generated tremendous interest from both patients and providers. They can offer the opportunity for seniors to receive convenient, accessible primary care from a physician that they know at a predictable and affordable cost. Better access to primary care, as we all know, can prevent more serious and costly ailments. We look forward to consulting with all of you on how this might work because it would be a significant step, representing the kind of fundamental rethinking of provider compensation that may be necessary to deliver value. The direct provider contracting proposal also reflects our interest in testing ways to reduce burden on providers, especially those that may be impeding care coordination. As you heard from Administrator Verma on Monday, we're well aware of the huge burden that regulation places on so many healthcare professionals and institutions, and we're working to reduce that burden where we can. Just so far in 2018, CMS has been able to pare back regulations that will save providers more than 4 million hours of paperwork. As just one example, we've been able to do away with some quality measures that were burdening physicians while no longer telling us any meaningful information. CMS also has a much larger regulatory reform package in the works. We call it Patients Over Paperwork, which I believe will represent a major step forward for patients and providers. I'm really excited about the work that we've done here, and the savings to providers and to our healthcare system will measure in the billions when we get all of this out. It really a landmark transformation in the level of burden for providers that will allow you to focus on patient care, patient delivery, and reduce cost in our system. So stay tuned. If you like what we've done so far, you're going to love what's coming out. A final point about the nature of government burdens. We're mindful of how they could be driving consolidation in the marketplace. Now, as a matter of principle, we and I want to move to a system where our regulations and payment systems are agnostic about ownership structures. Economics and competition should drive markets, not us. One place that we believe that could be especially useful is in coordinating care in rural settings. This week, CMS unveiled its first ever rural health strategy. Listen, we know rural hospitals in particular are a lifeline for the nearly 1 in 5 Americans who live in rural areas. And we're committed to maximizing the promise of technology and building new partnerships to improve care across our country. This is going to require novel approaches to care delivery and coordination. And we've got to ensure that we at HHS are not standing in the way of this needed innovation. Before closing, I want to touch on another priority that I've laid out as Secretary, bringing down the high price of prescription drugs. I wish I could give you a lot more detail on this today, but I will add this to the litany of complaints I have against Iran. That I wasn't rolling it out yesterday with the president, but will be coming on Friday. President Trump believes it is a top priority to build a system that puts American patients first, and HHS is focused on solving a number of the problems that plague drug markets. These include the high list prices set by manufacturers, seniors and government programs overpaying for drugs due to the lack of the latest negotiating tools, rising out-of-pocket costs for consumers, and foreign governments free-riding off of American investment in innovation. HHS's blueprint for addressing these challenges will build on the proposals put forth in the President's 2019 budget and the actions that he has already taken, but he wants to go much, much further. As you likely know, as I mentioned, the President will be delivering a speech on this topic on Friday afternoon, so please stay tuned. And I hope you will find much in this comprehensive effort that you can support and that will be of value to you and your patients. I want to conclude today by laying out why I'm so optimistic that we can bring transformation to all these aspects of healthcare under this administration. First, the time simply has come. The status quo just can't hold. You know this. You look at your balance sheets. You look at your patients. You know it. The way we do business in American healthcare simply must change. Today, we have a president who's unafraid to drive the disruption that we need in this system. President Trump's a man of courage and vision, and he's seen and heard how the high cost of health care is burdening so many Americans. He understands that our system too often fails to deliver value to them and to us, and he's given us a very strong mandate to do something about it. The measures that I outlined today will get us part of the way toward a system where the power of informed individuals will deliver high-quality, affordable health care. Listen, getting to that system is not going to be easy or the most comfortable process for entrenched players. You all are running businesses. I understand that. I ran a business. Okay? Systems work. But you have to change, and if you change and if you get there first, you're going to have an advantage. And America's hospitals have already shown a willingness to change, lead, and to innovate. That process just needs to accelerate, and we want to work with you to make that happen. And those players who are interested in working with us to build a new system are going to have unprecedented opportunities at hand. We all know change represents opportunity. So I exhort all of you to engage with us on the efforts that I've discussed today, take advantage of the opportunities they represent. Because I assure you, in American healthcare, change is possible, change is necessary, and change is coming. Thank you very much for the opportunity to be with you today.